All right, so we are recording today. We're going to continue on through understanding a little bit more about primarily looking at PALS for the pediatric patient. Now, in early versions of PALS, and ACLS came out much earlier than did pediatric advanced life support. Sinus tachycardia was considered to be a dysrhythmia for your patients. In most situations right now, sinus tach in the pediatric patient is actually considered a normal rhythm, or it could be potentially considered benign. So literally, it's kind of like, yeah, the child has a rapid heart rate, but can often be caused by things that are not life-threatening for the patient, such as fever, pain, anxiety. The child can be dehydrated, and we know that dehydration or tachycardia is one of the earliest signs of dehydration as the body tries to compensate for everything that's going on. But now, it can indeed go into things that are really, really serious, such as anemia, sepsis, and strangely enough, we're beginning to see more and more cases of septic kids primarily arising from what etiology? What would you think, as far as pediatrics go, would make our kids not just sick, but septic most often? Respiratory infections. Remember, children are little laboratories and factories for snot and bacteria and viruses. And when they get these things, it's going to stay in their body for a very, very long time. The other thing that we're looking at here, as we talked about on Monday, is incredibly important, is this role of hypoxia. Keep in mind, because I can tell you, you'll probably see this question on an exam. One of the earliest responses of the body to hypoxia in the pediatric patient is tachycardia, followed by when they move from respiratory distress into respiratory failure, and they're on that slippery path now going down into respiratory arrest, followed by a bradycardia. So one of the things that you have to watch really, really carefully and don't get fooled by is that you see a heart rate that will go up, and then all of a sudden your kid gets really calm, they get really quiet, the heart rate begins to fall down. It could mean one of two things, John. It could indeed mean, hey, what I've done is working. My child's getting better. Or it could mean my child's getting even worse. Or as a friend of mine from Texas likes to say, more worser. Okay? And that's the things that we typically want to watch. Other things that we would see with kids would be if they get into parents or their grandparents' medications. Now, what type of medications would normally cause a child's heart rate to go up?
Beta blockers?
Not beta blockers, because remember, beta blockers will act on children the same way that they do on adults. And beta blockers, Mark, is primarily to do what? Slow the heart rate down. Good. So what will cause the heart rate to go up, Allie? Not so much Tylenol, except really, really late if they get into the fatal stages. Because remember, Tylenol affects what organ? A Tylenol overdose is dangerous / deadly to what organ? The liver. Okay, go ahead. I'm sorry. I am having a terrible time hearing today, so I apologize. Adderall, you're exactly right. So we know that Adderall is a very, very strong type of amphetamine. It works well for adults to help adults to begin to focus, but it will also help children's heart rate to go up. What would be another common type of medicine that you would see that would cause a pediatric patient's heart rate to go up? Joe, what do you think?
I don't know. I know that. I don't know. That was
Okay. All right. So what do you think? I mean, think to commonly prescribed sympathomimetics that may raise the heart rate. What would be a medicine that you might see a child get into? Maybe we need to do a pharmacy assignment. So stand by for that, all right? So be thinking about that. I'm going to come back to it. We have other more serious but less frequent causes of tachycardia that primarily are relegated to trauma, okay? Cardiac tamponade. Cardiac tamponade will decrease the contractile force of the heart, but the heart will try to compensate by increasing the heart rate. A tension pneumothorax or a PEA. I'll be honest, I've never seen a pediatric patient with a PEA. I've seen them with tension pneumothoraxes. I've seen them with cardiac tamponade, primarily from trauma in motor vehicle accidents. Never seen a child with a PEA that comes in there. Now, here's the thing that we're looking at with sinus tachycardia. All right. Now, remember, we're talking sinus tach, not SVT. Okay. Is that we begin to identify the underlying cause. And as I've got in here, there are 8 different things that we're looking at here that help us to remember to look at underlying causes, okay? And I want you to remember these, all right? First one is airway, hypoxemia. We can fix that if we give proper positioning and we give proper oxygenation, okay? And if that doesn't work, then we go into B. We can fix that with ventilatory assistance, either through a BVM, either through advanced airway management, or at what point might you want to consider the use of CPAP in a pediatric patient? When would you consider using CPAP on a pediatric? Allie?
If, like, you're supporting their breathing and you're doing all the right things and their SpO2 still doesn't increase.
Okay. Is there an absolute contraindication for CPAP in a certain age child? Okay, let's take a time out here. Everybody's really quiet. Is there something else going on that has got everybody quiet? Or are these legitimately things that you don't understand? Because I want to do what's best for the class.
I legitimately don't know.
Okay, thank you, John. So basically what we don't do is we don't use CPAP normally in kids younger than 16. However, that's a relative contraindication that think about some of the things that we've already talked about in here that would, let's say you've got a 14-year-old, but you would say, I'm going to use CPAP on that child. What might change that would lead you into using CPAP on a 14-year-old? Allie?
Puberty.
Say it again.
Puberty.
Puberty. Okay. Again, keep in mind that when peds start showing signs of puberty, we now treat them like adults. We now treat them like adults. You have chronological age and you have physiological age. Okay. The example I like to give is my wife is several years older than me, But when you put us side by side, she looks much younger than me. And I like to tell her that living with me apparently has been really easy for her. And living with her has apparently, if you look at me, has been really hard for me. She then hits me and we move on. But again, you're looking at with pediatric patients, especially as they're moving into adolescence, as assessing them from their physiological age and not their chronological. C is circulation, all right? Your dosing regimen for a fluid bolus in a pediatric patient is what?
10 milliliters per kilogram.
How much?
10 milliliters
10.
per kilogram.
Yes. Again, when you decide that that child looks like and is physiologically functioning like an adult, then we change that dosing over to the adult regimen. Again, the other thing to keep in mind for, regardless of the age of the patient, you're going to listen to breath sounds before, during, and after any kind of a fluid bolus. Understand that the presence of crackles does not necessarily eliminate the administration of a fluid bolus to a patient. Okay, we've got to treat what's going to kill our patient first, but we definitely want to be careful that we do not either cause or make pulmonary edema worse for our patient. Look at the potential for drugs. One of the big things that we're seeing today is, especially with all of the opioid as well as the easy ways of making methamphetamines now, is that kids will be exposed to this either accidentally by them getting into it, or potentially what I would consider intentionally through the manufacturing process of just some of the byproducts. So one of the things that's incredibly important as far as trying to figure out why this child has a tachycardia that's going on. And now remember, when we're talking about a sinus tachycardia in a ped patient, we're talking about a heart rate that will be faster than what we would normally expect. Normal heart rate range for, say, a 6-month-old would be what?
It's like 100, 140 or something like that.
Yeah, so that would be normal. So even though we look at that and we say, well, that child is in a sinus tachycardia, we're not really too concerned about that until it moves up above that 140 mark that you've got in there that would be normal for that range. If we got a 16-year-old that's got a heart rate of 140, now we're thinking SVT, because now we've moved well beyond any type of sinus tach. So understand just kind of that range and the physiological impact that it can have on that. Drugs, caffeine, again, we see caffeine being freely used, freely accessible. We all partake of it. This is typically my process of increasing my caffeine intake. And so if a pediatric patient gets into energy drinks or anything along like that, that can cause it. Lower erythrocytes, anemia. Why would anemia result in a tachycardia, sinus tachycardia?
Just to compensate, because their blood really carry oxygen as well.
So let's do a little bit of a review here right now. What actually is anemia in the human patient?
Low iron.
That can be a cause, but that's not actually what it is. What is what is anemia in the patient? John? That can also be a cause that leads to the root cause of anemia. Both of y'all are right on the right track. Allie?
Decrease oxygen carrying capabilities.
On what protein?
Hemoglobin.
Hemoglobin. So the bottom line here is our patient is anemic when the hemoglobin is not able to carry adequate oxygen. What can cause that? Reduced red blood cells, okay? Reduced iron function or presence there, because iron is needed in order for the body to manufacture hemoglobin. Bleeding out is a type of anemia. We don't think about that very often, but when our patient has trauma and they're losing blood either internally or externally, now basically what happens here is that we have a reduction in hemoglobin and we see a reduction in the oxygen carrying capacity for our patient. So what is our primary goal as far as treating and addressing anemia? Because we're going to be limited as to what we can do, but it's going to be critically important that we do what we can on the way into the hospital. So what will we do for these patients that are anemic? Remember, we're looking at treating underlying causes of sinus attack. Bella, what do you think? We're going to give them oxygen. Why would that be important? So if they're not able to carry oxygen as well, why would giving them additional oxygen work, even though it's the right answer? And not just Bella, but anybody. Joe.
What's the difference from room air compared to like tank oxygen?
Yes, the partial pressure of your oxygen. When we increase that partial pressure in the alveoli, it makes it much more available for our patients to, remember that word diffusion, for it to diffuse over into the capillaries and link up with the hemoglobin. This is in essence what happens with patients, regardless of their age, that suffer from carbon monoxide poisoning. One of the really cool things that you could do for a patient who has carbon monoxide poisoning, if they're awake and they're able to talk, is put them on CPAP. Why would CPAP be a good thing for them, even though they're not having respiratory distress? Nausea, vomiting, headache, maybe a little lethargy. Why would CPAP be a good thing for patients in carbon monoxide poisoning? John?
Forces the oxygen in.
It forces, okay? And remember, with carbon monoxide, it has a 200 times affinity for hemoglobin that the oxygen does. And so literally we got to go in with a crowbar and we got to pry the CO off and replace it with oxygen. So again, increasing that oxygenation, increasing the partial pressure, like you said, Joe, is going to be a very good thing when we've got a patient that has anemia as well. Fever, very, very common type of situation that you will see with your pediatric patients, especially those younger than 4. And this will often result in a tachycardia as well. Why? Because it's the body's effort to fight off whatever the bacteria or the virus is that is trying to attack it. Glucose, hypoglycemia, all right? And so remember, when we're talking with primarily with toddlers or younger, we don't do a finger stick because you're not going to get enough blood from their fingers yet until they get older, but we'll do a heel stick for those particular patients. And the last one, I love the way that they categorize this, because this is not original with me. Holy cow, that hurts, okay? Anything that you do that's going to hurt the patient. If you do a finger stick, if you're going to give an injection, if you're going to set a fracture, that's automatically going to cause their heart rate to go up. All of y'all are very approachable. You're very friendly. You're very compassionate. You're normally a little more talkative, but I'll cut you some slack on that today. But again, when you come in, you are going to be a threat to children that you come into contact with, and they're going to recognize you as a threat, and so that will bring their heart rate up as well. So again, here's the key, Claire. When we're focusing in and we've identified a child that has a sinus tachycardia, Our goal for that child is to address the underlying cause. That's the same goal if we're dealing with a 99-year-old male or female with a sinus tachycardia as well. Find out what's causing it and address that, okay? Any questions or comments on sinus tachycardia treatment as we're going to move into SVT now? Joe.
So with kids that are under the age of 10, it says yesterday you said they can go all the way up to 140, which is sinus tach. And for ages 0 to 3 months, so they can be as high as 205. Are we just looking to see if they're symptomatic, or are we just going to treat underlying causes regardless and see if that fixes it? And then if it doesn't, we go with they're fine, or do we take them to the hospital? Obviously, we listen to the parents and go from what they want. But
so I will tell you, Joe, you've answered your own question, which I love it with this class because y'all do this on a regular basis. Let's say in this situation, you've got, let's say you got a 13-month-old. Heart rate is, let's say, about 222, okay? Where do you start as far as deciding, is this a problem or is this not? Think back to the pediatric assessment triangle, okay? Remember all of that. Where do we start with that particular patient?
Look at their work of breathing.
Look at their work of breathing. What else? Skin condition. What else?
Their pulse strength and blood pressure.
So we can try to get a blood pressure, but their pulse strength would give us some good indication. What's one of the earliest indications of poor perfusion? Level of consciousness. Okay, so you're taking all of those into play. If there is an issue that is in there, where would you start? Now, we really haven't moved into SVT, but we're getting ready to. But where would you start as to determining, is this a sinus tach problem or is this an SVT problem? Allie. So that's another thing. We would look at their perfusion. Again, that kind of comes back to what you said. We would look at their skin. Comes what Mark says as far as looking at pulse strength and blood pressure. But remember, when we're taking care of our patients, regardless of their age, but especially with kids, start with the simplest, most appropriate treatment first, and then work your way up. If you go to the nuclear option, as we'll talk about in just a few minutes, if you go to the nuclear option, you really don't have anything to move on to. So one of the first things that I would say in regards to your question here, Joe, and it's a good one, is that get your assessment of your patient. Look at these categories and see, does your patient fall in one or more of these categories? Is the child running a fever? Okay. If it is, that's probably the problem. We'll talk about some childhood diseases a little bit later on, and we'll talk about when it's appropriate to cool a child and how to do that so that we don't cause problems later on. If there's a hypoxic issue, we begin to address that first. So we start with the smallest area, the simplest area, and then we work up to more complex. Mark.
So if you did have a small child in SVT, like before they're able to speak, how would you go about vetting them if you can do that?
I'm glad you brought that up because that's our next slide. Okay? So now the most common dysrhythmia, I'm sorry, John.
What was the sympathomimetic drug you were trying to prompt us?
I didn't have anything in mind. I wanted y'all to come up with some. So again, digitalis would be one that would cause. Dig does what for an adult? I'll come right to you, Allie. Dig does what for an adult?
It's like an old anti-dysrhythmic, right?
It's an old antidysrhythmic, and it's given to patients that are in heart failure, and it increases the contractile force of the heart. Remember, with the pediatric patient, generally what we're doing is we're looking at kids that are kind of toddler age here. It's kind of, oh, look at the pretty colored candy, and they swallow it. Not only for kids will it cause increased contractile force, which it does, but they will also, because their conduction system is not fully developed yet, their heart rate will go up as well. So DIDGE would be one good example of that. So I would tell you to do some research, because I think I found a bonus question here for your next exam. Okay, it's just kind of a fair warning. Allie.
With blood thinners, also,
Why? Yeah, why?
they can't vasoconstrict as well. So the only way they can compensate for that would be tachycardia.
Yeah, and that's not a sympathomimetic. That's awesome. Yeah. So your child gets into grandparents' warfarin. All right, warfarin is kind of being phased out just simply because there's so many dangers with it, and patients have to be tested on a regular basis, and it's being replaced by drugs such as Eliquis, which are safer and are less likely for kids to get into, of course, because you have to go in for an injection for that. But they are still out there. Now, let me ask you a question. Where might a pediatric patient get into anticoagulants that are not medicines? Allie.
Alcohol?
Alcohol's not so much of an anticoagulant. Rat poison. If you look, next time you go to Walmart, next time you go to any place, hardware store, pick up a box of rat poison. Look at the ingredients. The ingredients will say warfarin. And what it does is it causes rats to begin to internally bleed. Where do we put rat poison? Down on the floor, in the cabinets. Where do toddlers love to be? Down on the floor, into the cabinets. And so that's kind of an area to kind of also remember that your child could get into an anticoagulant that is not prescribed. You know, it could be the child of a young couple. And again, they're trying to control the rodent population, and as a result, getting into that medication or that substance for the child. Any other questions as far as that goes? So I would encourage you to do some research on drugs that would cause the heart rate to go up on your pediatric patients. All right. As I said, SVT is the most common rhythm that we would see for kids. Now, the prognosis for SVT with pediatric patients is really quite well. They do respond to both vagal maneuvers and to an adenosine really positively. Now, some of the things that we would see in addition to SVT with a child would be poor feeding. The child just doesn't feel like eating. Why? Because they don't have enough perfusion to eat. They're irritable. As an adult, adults that have SVT don't feel good. They're able to verbalize that. With kids, their verbal skills may or may not be up to the ability of them to be able to look at you, John, and say, I don't feel good. So they cry. They're cranky. They're irritable. Their respiratory rate will obviously go up again because SVT reduces your preload. And our cardiac output, we know, goes down during a reduction in preload. These kids could just simply look septic to you. What is one thing that you wouldn't find with kids that are suffering from SVT that you would find in a septic child? Joe. Fever early. What would you normally find with sepsis late? Hypothermia. My class is coming back to me. Thank you. So hypothermia. Yeah, you're exactly right. So again, we don't want our kids or even adults to get into that stage because they're right there on that doorstep of irreversible shock because everything is beginning to fail when they become hypothermic. Now, generally what we're looking at here is that kids will have, when they're born within the first 24 hours, their heart rate will be really, really high. That's normal. So we don't really have to worry about that too terribly much. Now, how do we address SVT in the kids? Now, we know for adults, for our simple options is that we move from vagal maneuvers all the way up to cardioversion. But the question was, and a good one, how do we get children to do vagal maneuvers? What would be some of your suggestions? Let's start with you guys first.
Blowing on a syringe.
Blowing on a syringe, okay? So if you've got a toddler that is at least mobile, maybe you're able to take and make it into a game, okay? And so have them blow on a syringe. What else could you do for, let's say, a toddler or older? Remember, your goal is to increase pressure in the chest, putting pressure on the vagus nerve to help to kind of slow that SVT down. Joe,
Breathing exercises?
tell me more. What?
Box breathing and take a deep breath in, hold it.
Okay, there you go. So again, with kids, you got to turn this into as much of a game as you possibly can because they're not going to understand why you're doing this. So in regards to what you just said, not so much box breathing, but the latter part was spot on. Okay, it's kind of like, all right, you're the paramedic, I'm a 4-year-old, all right? Not a far thing to imagine for me. And what we're going to do is you tell me we're going to have a breath holding contest to see who can hold their breath the longest. 1, 2, 3, go. Take a deep breath and hold your breath. So that's going to help that. The other thing that we can do, I've never done this because I've only occasionally, and thank goodness you don't see SVT in peds very often. The other thing that you can do is if you've got a child that is not able to follow directions, they're not able to blow on a syringe, they're not able to hold their breath, is that you tell mom or you tell dad, okay, I need a big bowl, or for in the home, all right, we're going to take this sink and we're going to put a bunch of ice in it. And then we're going to fill this up with water, okay? And we're going to activate the mammalian diving reflex. One of the things that kids will automatically do is that when you put their face in water, they will automatically hold their breath, okay? They'll automatically hold their breath. And so by putting the child's face in ice cold water, and it's got to be cold, it's got to have ice in it, it's got to be really, really cold. What that does is it will force the child to hold its breath. Now, this is not going to be pleasant for the child. It's not going to be pleasant for you either, because it's definitely not going to be pleasant for the caregiver, and especially if mom is there, because moms are very, very protective of their children. Not saying that dads aren't, but moms raise it to a whole new level. So you've got to, this is one of those situations where you gotta get the caregivers on your side. You got to explain to them why you've got to do this in order to bring that down. The other option that you would have would be putting ice in a cloth, not a plastic bag, but in a cloth, and then just laying it over the baby's mouth and nose. Similar thing will happen. It's not nearly as effective as just simply putting the face down in the water. We're not going to put the whole head down in the water. We're not going to put the whole body in the water because now we change everything up into a possibility of a hypothermia. But again, holding the child, putting the child's face down for basically about 5 to 7 seconds, just long enough for them to hold their breath and build that pressure up. and to watch your hopefully your heart rate drop. Questions on it? That's your simplest. That's the first thing area that we're going to work up to. So questions on it, Joe.
How quick can you see results with that? Because I can imagine that would cause anxiety. And if they read off their parents' expressions, if they're that coherent still.
Love the question, because you're exactly right. Children are always going to look to their caregivers as long as it's a good relationship, and most of them are. They're going to look to their caregivers to identify whether or not things are dangerous. It's kind of like me. I do a lot of flying. Sometimes we get in a plane and the plane starts making weird noises. It starts making weird movements. And I always look up to the flight attendants and say, okay, if they're not worried, I'm not worried. So I kind of understand that. In that regard, what you got to do is you got to explain to the parents before you do this. Now, again, remember that the parents are the legal guardians of the child. If they say, you're not doing that to my child, then you would move on up into potentially adenosine. And then if that doesn't work and the patient continues to deteriorate, then we would go to cardioversion, which we'll talk about in just a little bit. But again, one of the things that's important that you brought up there, Joe, is that it's important to let the parents know that their child's going to feed off of their anxiety. It's okay for parents to be scared. Don't tell them not to be afraid. This is their child. They're going to be afraid. But try to get them to mask that as much as possible to help the child. Good question. Anybody else? Yes?
Are we also possibly worried about if it panics the child, it also increases the heart rate? Because if we're inducing a little bit of forced drowning almost, like want to kind of freak them out?
It is a type of forced drowning for short term. If basically what we're looking at here, and it's, we want to bring that heart rate down. So basically what we're looking at is that if they're in SVT, they're hemodynamically unstable, okay? And we're looking at the degree of that instability. Now, yes, what we want to do is we want to bring it down, and hopefully we'll bring it back down into like a sinus tach range. After you do that, the child's not going to trust you anymore. And so their heart rate is going to stay elevated for the very reason that you just said. Again, if we can get a 10 to 20% drop in the heart rate, we can live with that, okay? Even though the child is going to be frightened of you. But the good thing would be, hopefully, you won't have to do anything else to the child for that cause. Excellent. Kira.
Would there be any kind of indications that you would want to bypass the ice water?
So what would be an indication now that you would want to, okay, we're not going to go this route. We're going to either go with adenosine or we're going to go with electricity. What would you see? I'll let you on a little hint. Same criteria for an adult. Allie?
Level of consciousness?
Unresponsive or altered mental status, okay? Now what we're looking at here is that we have what I call symptomatic. Now, again, I don't like that terminology, Kira, because the parents have called us for some reason. The child's irritable. The child won't eat. So those are indeed symptoms. I guess probably the better terminology is the severity of the symptoms.
What if the kid was crying a lot? Like, would you want to hold off, or would you still do it?
If the child is crying a lot, what does that tell us right away? What one thing does that tell us, Mark?
They're stable enough to cry.
They're stable enough to cry, and they have what? Okay, so they have energy, but even more important than the energy. Say again? A patent airway, yeah. So that tells us that this child is keeping their airway moving and open. So again, crying would actually be a good sign that we would see. I like to say that a crying baby means a happy paramedic, okay, because they're moving air in and out. And why is that so important? Because remember, Most medical issues that you'll respond to with pediatrics have to do with airway and breathing. So if the child is crying a lot, we're moving air. So I probably would not take that by itself. But again, if the child is crying, and if it's not a vigorous cry, now we're getting into that kind of that lethargic stage. Go ahead.
Would they aspirate on the water? Is that
They're not. Okay, so here's the thing that will happen is that as you begin to put the child in the water, you're going to turn them upside down and hold them kind of like this way and dip them down. So as their head starts to go into the water, that's immediately going to stimulate that mammalian diving reflex, that protective mechanism for them to hold their breath. I'm sure I won't remember this, but one of the things that I've seen demonstrated with this is that they teach babies to swim, okay? 6-month-old babies are learning how to swim. And basically what happens is the instructor and the parent will go out there and they will put the baby out in the water, and the baby sinks, holds his breath, and comes back up, and then will automatically begin to dog paddle. So this is a protective, this is an inherent mechanism that the body is designed with, especially for kids, that the possibility of aspiration, which is one that's really, really important, Karen, I'm glad you brought it up, is very minimal. So excellent job. Anything else on that? So, Joe, do you have something? Okay. So when we're looking at what we're going to do is that we're going to look at the severity of your symptoms. Okay. Our next stop is going to be adenosine. Adenosine has to be administered just like it does for an adult as far as the method. What is the key thing we have to remember when we're giving adenosine? John, you got to push it fast, and what else? Follow it with a fluid bolus so that it will get to the heart fast. Good. So the adenosine, that basically what we're going to look at here is going to be about 0.1 milligrams per kilogram for your patient. We're not going to give a lot. It's got to be given very, very quickly, okay? Now, the other thing is we can double that, and we're only going to give it twice, okay? The big thing with adenosine is I'll never ask you, and to my knowledge, I've never seen this as a question being discussed as a potential question for the registry and all the work that I've done with them. It's important that you would know that adenosine is one of your options, but I will never ask you for the dose of adenosine for a pediatric patient. I will expect you to know it. I will expect you to know that you got to give it fast. I will expect you to know that you got to follow it up with a fluid bolus. I will expect you to know, Claire, when it's appropriate to give adenosine as opposed to going with vagal maneuvers or cardioversion. But again, that is a drug that I've only given adenosine to kids twice in my entire career. You guys are probably going to give it more often, maybe, but hopefully you're going to look that dose up, because I would much rather, especially if you're using a Handhavy app, you're much more important to be right than looking smart. Allie.
I looked at the quiz this week. I just want to let you know there's a lot of dosages on that.
Let's say it again now.
There's a lot of dosages on the quiz this week.
That's there because you can look them up during the quizzes. So again, I want to get you familiar with that whole process. So that's on purpose. But on an exam, the only dosages that I expect you to know up to this point are which two drugs? Epi and atropine. Epi and atropine. Okay, and especially epi. Especially epi. All right. Now, if adenosine doesn't work, or if the patient is so unstable that we've got to go to the nuclear option, generally what we're going to do is we will start out with 1/2 to 1 joule per kilogram, and we can go up to 2 joules per kilogram, and that's where we would stay, and we would repeat. Have you guys done other than what we did maybe with some of the open labs? Is everybody utilize the defibrillator on the monitor that you feel? Okay, awesome. I see head nods. Excellent. All right. And so again, what we're looking at here is an actual, like I said, the dose for adenosine, and this is going to be true for a lot of your ACLS drugs, is going to be that 0.1 milligrams per kilogram. For peds, it's going to be weight-based, whereas for adults, it's simply just going to be the 6 and 12. And then we can double and we can go up to 0.2 milligrams per kilogram. If you give adenosine, will it be effective if you start an IO?
Oh, yeah.
Tell me why. Defend your answer.
You showed us an X-ray. Went to the heartbeat quick.
So remember, we looked at that X-ray, and in the adult, how long did it take for the fluid? Now, the X-ray I showed was the humeral head IO. How long did it take for medicine to get from here to here? Does anybody remember?
2 or 3 seconds.
2 or 3 minutes. Now, let me ask my question again. Is adenosine going to be effective through an IO, even if it's a humeral head IO in a pediatric patient? Probably not. Probably not. Okay. And so this is going to be another one of the reasons why digging into that whole concept of finding out why this patient is struggling with the SVT, to make sure that you've addressed all of the underlying causes for that, is going to be critically important. So again, adenosine generally is not going to be really, really effective unless we are able to give it really, really close to the heart, directly into an IV for our patient. Now, when we're looking at this, the big thing is go back, and one of the things I want you to review is what adenosine does as far as stopping SVT. So does anybody remember from your ACLS or from your 310 as to how adenosine works in the heart? I'll take that as a no. Okay, not a problem. Now, basically what it does is that it attaches to the adenosine receptors in the heart, and it blocks the impulses coming through the AV node. Okay, so in essence, what's happening here is that it's stopping all those impulses to go down through the bundle of His, bundle branches, and up into the Purkinje fibers. So by doing that blockage in that area there, what's going to happen is now, hopefully when it works, is that our heart rate is now going to be slowing down. Remind me of some of the side effects, plural, of adenosine. Chest pain. What else? The chest pain primarily comes about as a result of what? Yeah, we put our patient into a short period of asystole. Could last anywhere from 6 to 12 seconds, okay? Again, remember we talked about in 310. Don't tell your patient you're going to stop their heart. Turn the volume down on your monitor. Turn it away from your patient. Do all of those things for the caregiver as well if you're having to give adenosine to a pediatric patient. What are other side effects? Skin flushing, okay? A lot of patients will say that it feels like that they have been incontinent of urine for their entire body. So they will have this warm sensation from the top of their head down to the bottom of their feet, and it happens all at one time. So that's skin flushing. What's another one? Claire? Say it again.
Diaphoresis.
Diaphoresis, okay? Again, coming from the chest pain. Keep in mind that when we have chest pain, anxiety goes up. The sympathetic nervous system kicks in. And now, basically, what we're looking at is that diaphoresis kicks in. One of the things you want to keep in mind is that adenosine is inactivated by theophylline. Anybody remember what theophylline is? It's an old drug. Theophylline, also called aminophylline, is an old drug that is given to COPD patients. You don't see it much anymore, but you still may see it out there. But it's inactivated by theophylline. It's also inactivated by what other very, very common drug? Caffeine. Okay. So if you are called, let's say you're called to a party, a bunch of high school kids get together, their parents are out of town, and they're chugging alcohol and energy drinks or whatever, and the child has a lot of caffeine in its system. Understand that adenosine is probably not going to be as effective. In that situation, what do? Do you just simply go to your nuclear option and light them up? Or do you do something different?
Fluid.
So we can give them fluid, and that might help raise their preload, which will help their cardiac output. So that's not a wrong answer, but it's not going to slow down the heart rate. What might you want to consider doing?
Vagal maneuvers.
So you do vagal maneuvers, it doesn't work.
Because of caffeine.
Say it again?
Because of the caffeine.
Because of the caffeine. Well, the vagal maneuvers are not working just simply because you gave me the right answer, and I'm going to tell you it's not working because I'm kind of putting you in a Kobayashi Maru situation here. Vagal maneuvers don't work. Kids been chugging Red Bull for all night. You know that inactivates or it makes adenosine less effective. Call Med Control. Med Control will probably tell you to start out with 12 and 18. Okay, 12 and 18, or maybe even 12 and 24 of your adenosine. Now, that depends upon how much you're carrying on your truck. So basically, if we double the dose, which can get into kind of, because generally what we're looking at is, for the first dose, probably not going to be a problem. But for the second dose, especially if it's 18 or if it's 24, that's going to require 2 vials. Allie?
Will that increase the length of time that the airways is stored?
Probably not. It's a good question. So her question was, will that increase the time of asystole? Is that what you were asking? Well, will that lengthen out the period of asystole for them? And I said probably not. Why?
Because of the drug's half-life and everything, it's still the same. There's just more of it.
There's more of it. The drug's half-life is the same. And what else, John?
The receptors can only take so much density at one time.
The receptors can only accept it. Okay, these are all correct answers. What's a third one? Why? Go ahead. That's the third one. So we're giving more to overcome the caffeine. Okay, overcome the caffeine. All right. Now, keep in mind that if you've got a pediatric patient with no toxidrome history, more than likely what they've got going on here is that they've got some type of congenital heart defect, and they're going to have to be assessed, they're going to have to be checked, and they're going to have to be treated in that. Keep in mind that for a pediatric patient that has repeated episodes of SVT, they will typically go in for an ablation. What's an ablation?
Like if there's a defective nerve, you go and like burn it.
Mm-hmm. So they'll set up an appointment with an electrophysiologist. This is a PhD level, not always a physician, though. The electrophysiologist literally will go in and will map out the conduction system of the heart through multiple tests. It goes way beyond my knowledge. But basically what it does is they will identify the conduction system, the electrical system of the heart. They'll identify, remember, it's usually a cell or two together that has gone rogue that is causing the SVT. So again, this kind of comes back to that whole process that we learned early on in 303 of the automaticity of the heart. Every cell can generate its own impulse, whether it's in the atria or whether it's down in the ventricles. Generally, this is going to be up in the atria. So what they'll do is they'll literally do just what you said. They'll go in and they will destroy that area of cells, not with so much with a laser, but they use radio frequencies to go in because it's much more pinpoint and the energy level is much less, so that there's less collateral damage around the rest of the heart. Generally what happens in that situation, that takes care of the child as they grow on into adulthood. They don't have any more problems with this. This is a procedure that adults will also have quite often for what two cardiac conditions? We'll do a little bit of cardiac review here. What two cardiac conditions would you hear of a patient maybe having an ablation on? That's one. What's the other one? The other one is really common. AFib. AFib. So WPW and AFib. So those are the ones that you would see with adults. Questions about SVT in the pediatric patient? Atrial flutter and atrial fibrillation, okay? Generally what we're doing is that with, yes, Allie?
Sorry, but did we talk about cardioversion? Like how much?
Yeah, cardioversion, the process for cardioversion is the same with the exception of, because of the size of the child, going anterior, posterior with your pads is probably a better route to go. And your dosing regimen, for your first cardioversion is going to be 1/2 to 1 joule per kilogram. And then your second and the subsequent cardioversions would be 2 joules per kilogram. Close does count. One of the things that we're finding out in medicine is that people do not estimate weights very accurately. It's not just EMS, it's in nursing, it's doctors, it's anybody else. So get as close as you can. One of the best ways of identifying a child's weight is to ask the caregiver, because they typically will hold on to that. Any other questions on cardioversion? Okay, so cardioversion, the same process is the same. It's got to be synchronized. And I remember when you're using the sync on the monitor, you got to push and hold, as opposed to defibrillation of when you touch the button, it immediately delivers it. It's got to find that marker up that marks out the R wave before the energy is delivered. Any other questions on that? Okay. AFib, aflutter. We talked about congenital situations such as rheumatic fever can lead into some issues with patients, as well as cardiomyopathy. Cardiomyopathy is what? It's a congenital type of problem, but tell me exactly what is cardiomyopathy? Yeah, so basically, remember that the heart, when we stretch it, it snaps back. Starling's law, okay? But if that heart stays stretched too much for too long, now the heart begins to become flabby. We see cardiomyopathy more so in what types of patients? These are adult patients. But generally, where would we see cardiomyopathy caused more commonly in adults? The cause.
elderly patients?
that have a history of what? Yes, elderly would be one.
Which is cardiac history.
So cardiac history would come into there. Yes.
A history of hypertension.
History of hypertension. Why hypertension?
Just to guess, but like the high blood pressure is expanding on their heart, pushing on it more than normal for their whole life.
It's a good guess. It's a good guess. Okay. So basically, remember, we talk about preload. Preload is volume of blood that comes into the heart. Afterload is the pressure that the left ventricle has to overcome. If that pressure remains up and it is sustained for a long period of time, now that heart begins to get larger, okay? It gets to a point now, though, where it gets too large and it becomes floppy. So afterload or hypertension is a huge, huge problem that has to be addressed. Generally, we see it in older patients. It is a chronic, slow-developing problem. So if you've got it in children, it's going to be primarily from some type of a birth defect that's going to come into play. Kids with cardiomyopathy are at an extremely high risk of cardiac arrest. Okay, so they are watched very, very closely. Now, generally what we're looking at here is that if we have kids that have AFib with a rapid ventricular response, which means when I say AFib with a rapid ventricular response or RVR, from a physiological perspective, what's actually happening? What causes that rapid ventricular response?
Is it the ventricles trying to compensate for the atrial fibrillation?
Not quite compensate, but it's definitely involving the ventricle, of course. Mark.
It's like re-entry of the signal through some nerve.
Not so much re-entry, because remember, AFib is basically all of the cells up in the atria itself that are all firing, and most of the time, those get filtered out where? At the AV node, okay? With RVR, the AV node does not do a good job of filtering those out, so it lets an inordinate amount of those impulses through, which results in a rapid ventricular rate, which does what to our patient?
Makes them go into tachycardia and SVT.
Say it again now.
They'll go into a tachycardia.
They're going into a tachycardia. That's what our RVR is. But what does that do to our patient's cardiac output? Because it does what, Allie?
It goes down because you're not really getting any preload or anything like pushed well to the ventricles, and then they're still beating rapidly in the ventricles, so then you're not pushing anything out. And
Perfect. Yes, you're exactly right. So, and this is true for any type of supraventricular tachycardia, whether it's SVT or AFib with RVR. Okay. Now, one of the things I want to remind you is that you got to be careful. This is more so for adults, but you want to be really careful in your identification of whether your patient has an SVT or an AFib with RVR. If you're deciding to give adenosine, why is that?
I guess if it's RVR, then as soon as you give the SVT, once it comes back, it's just going to start up again.
Yeah, and basically what's going to do is it's actually going to open up that floodgate right there at the AV node that was supposed to block those off and let all those impulses through. So your patient, even though they're in AFib with a ventricular response of, let's say, 140, that could actually double. And now we've taken a bad situation and made it worse. Sometimes you look at your patient's EKG and you go, I'm not sure. I'm not sure. In that situation, you got to make the best informed guess that you possibly can. Let me back up. The best informed decision, not guess. We don't guess on patients, but the best informed decision that you can for your patient. Again, remember, your cardioversion dosing regimen is what? Regardless of whether it's SVT or AFib, for pediatrics. What did I just say a while ago?
For adenosine?
Cardioversion. Electric cardioversion. Allie.
1/2 to lift rule.
If that doesn't work, then to what? 2. Good. Very, very good. With patients in AFib, cardioversion may be the only treatment that we would go with, because we want to kind of hold back. We don't want to give adenosine for our patients. Okay, so get them ready for pacing. Be ready to transport them into a hospital. Now, the big thing with AFib for patients, for pediatric patients, is that their long-term prognosis depends upon how quickly the hospital is able to map out their electrophysiology or their electrical pathways, and how quickly that they are able to terminate those so that the rest of the heart can continue to develop. Questions about AFib, A-flutter? PVCs. PVCs in the pediatric patient are relatively rare, okay? Generally, we begin to see more PVCs in the pediatric patient when they start to go into adolescence. Most of the time, we're not really concerned about PVCs unless it looks like it's going to be some type of a problem with our own T, if we get multiple ectopic ones, or if we begin to see coupling or larger. So generally what we're simply going to do is we're going to just kind of watch the patient and treat the underlying cause that may be coming into play here. Now, again, there is a type of condition that you need to be aware of that in essence mimics an R on T with a PVC, and that's called what condition? We see it in sports. We typically see it more frequently in baseball and softball than we do any other sport. What is that?
Smack the heart with a lot of force and it goes into ventricular fibrillation.
And what causes the ventricular fibrillation, Mark? What causes the ventricular fibrillation and commotio cordis?
Basically, there's a force on the heart which causes an impulse during the relative active period.
Bingo. So in essence, what we've done is that we simulate an R on T. Generally, what happens is the patient gets hit in the chest, happens on the relative refractory period, excellent answer, and now our patient goes into ventricular fibrillation. That's the bad news. The good news is most of the time, these are healthy young people who have no cardiac issues. So if we have an AED available, these patients respond really, really well. There have been a few high-profile incidents of this over the last few years, and now we see more and more school systems that are requiring AEDs to be at baseball games and softball games. Usually it's more so baseball than it is softball. Why do you think that might be? Allie? The velocity of the smaller ball means more concentrated energy. What position on the field, or what positions on the field, are the most common ones to experience commotio cordis? John? Third baseman and pitcher. Third baseman, because a lot of players will pull the ball and they'll send it right down the line and it has a lot of force. Pitcher, because the pitcher is closer to the batter than anybody else on the field. okay, with the exception of the catcher, but you know, not going to have to worry about that part. So that's the big thing that we're looking at for these particular patients. All right.
Hear about the Bills player?
Yeah, yeah. The same thing happened with him after a tackle. This is one of the reasons why, you know, they're really focusing in on the use of the helmet. Primarily, they started out that the rules for targeting to prevent head injuries, but in essence, what happened was he got hit in the chest. And think about the force that it took to cause that for him, because he had protective gear on his chest as well.
My mom was actually in the ER, or in the ICU that he got brought to. So.
In Cincinnati?
Mm-hmm.
Really?
Yep. It's pretty cool.
Awesome.
He's got lots of, I don't have to interrupt majorly, but there's lots of stories there.
We may have to have her come in sometime.
Yeah.
Okay. So that's pretty awesome. Yeah. And so it raised the whole concept of early CPR, early defibrillation for the general public. And that was one good thing. And that dude has returned to football, you know, so he's happy and healthy. So I'm going to stop there. What we will do is we will finish up. I've got just probably about maybe 10 more slides on this to finish out basically the PALS part of it. And we'll finish this up on Monday. Guys, you need to make sure that you begin taking your Red Monsters, your ACLS guides, and memorizing those PALS algorithms. We will have PALS in the summer, and so you'll need to pass that as well. And so we'll do some practice in here. We'll probably have some open labs to help you to do some practice in there as well. But the big thing right now is to stay current with everything that we've got in 305, but in particular, those algorithms in your pocket guide. Any questions for me? All right. Hopefully the storms have already blown through, and I'll talk to y'all later. Oh, they're in there right now, and I'll be adding more later next week. So help yourself. Take as many as you'd like. Well, obviously, I love cardiology, so